Hi guys, I'm Dr. Shubhi Aggarwal and today let's study about IUGR or FGR, that is Fetal Growth Restriction. It is the failure of the fetus to reach its genetic growth potential. In utero. Now this is regardless of the fetal size. This puts the fetus on increased risk of perinatal morbidity and mortality. Now, to understand FGR, we first need to understand what is SGA and the difference between SGA and FGR. So, SGA is small for gestation age fetus. Now, any time that the expected fetal weight is less than the 10th percentile, it is called as SGA. So, say the fetus at 24 weeks was supposed to weigh 600 grams, but we have our fetus over here. So, this is an SGA fetus. Now, what is FGR now? FGR, either the rate of growth is not normal, or secondly, you have abnormal Doppler. Alright, for example, we repeated the scan at 26 weeks, the fetus is here, 28 weeks it is here, 30 weeks it is here. Now in this chart, the rate of the fetus is normal, the rate is normal, so we will call it SGA. But supposedly at 24 weeks we had the fetus weight over here, on 26 weeks here, 28 weeks here, but on 30 weeks we had here. Now this will be FGR because it is SGA plus abnormal rate of growth. Other than this, Doppler findings I'm going to tell you in later in the video. Now what is severe SGA? If the fetal weight is less than the 3rd percentile. So let's say here somewhere around this is the 3rd centile and the fetal weight is here, then we call it severe SGA. Now coming on to the causes. The number one cause is fetal malformation. Then we have genetic abnormalities. Now in both these conditions, there is abnormal cell growth and proliferation. Due to which there is intrinsic growth potential limitation and which results in FGR. Now then we have multifetal gestation. That is either twins or triplets. Now why does it happen? There is placental crowding. Meaning that the surface area of the uterus is less and the fetus does not have the space to grow. Less surface area means less nutrients, less oxygen supply, which leads to decreased growth. Then, then we have poor maternal weight gain. This can either be in malnutrition or poverty. Then maternal medical conditions. Maternal medical conditions. We can have asthma, chronic hypertension, cyanotic heart disease. All of these conditions, they lead to uteroplacental insufficiencies. Then we have infections. We have cytomegalovirus, we have toxoplasmosis, then we have syphilis, we have malaria. So these infections, they cause placental insufficiency, or they cause direct fetal organ damage. Direct fetal organ damage or placental insufficiency. Then we have uteroplacental insufficiency. In these we can have hypertension, preeclampsia, Apla syndrome, smoking, diabetic vasculopathy. Then we have certain drugs that cause FGR. The names of the drugs, anticonvulsants, they can cause FGR. Methotrexate, etc. Now let's discuss about the pathophysiology of FGR. How does it happen? So see, in FGR there is decreased blood flow to the fetus. Now since there is decreased blood flow, there is an adaptation mechanism in which the fetus redistributes its blood to the vital organs. Redistributes blood to vital organs. For example, more blood to brain and heart. This is called as brain sparing. Another thing that it does is less blood to kidneys, which can cause oliguria. And we have oligohydramnios, because we know that the amniotic fluid is made from the urine of the baby. If the baby will pee less, less amniotic fluid will be made. Now, and due to less blood supply, fetal liver glycogen stores, they start depleting. Which leads to decreased liver span and decreased abdominal circumference. Now, this is the single most predictor, and it is the most important predictor in the diagnosis of FGR. Now we have divided FGR into early onset and late onset according to the Delphi consensus system. So here we are talking about early onset. So what is early onset FGR? It is less than 32 weeks. At any time less than 32 weeks, if you find out that the abdominal circumference of the or the expected fetal weight of the baby is less than the third centile, or or there is absent end diastolic flow in umbilical artery, or if AC or EFW is less than 10th centile, so this is SGA. Plus, what abnormalities will you find in the Doppler? The pulsality index of uterine artery and umbilical artery will be raised, that is more than 95 percentile. Now in the late onset, it is more than equal to 32 weeks. In this, abdominal circumference and EFW are less than third centile, or there can be two of the three. Okay, AC and EFW less than 10th centile, or they are crossing the centiles of two quartiles, more than two quartiles, or CPR, that is cerebroplacental ratio is less than fifth centile, or umbilical artery pulsality index more than 95. So you have to remember this is the Delphi consensus criteria in which we are dividing the FGR into early and late. Now any time if the abdominal circumference or the expected fetal weight is less than third centile, we call it FGR. But in late weeks, if the is but if the abdominal circumference or expected fetal weight is less than the 10th centile, then we need to have an abnormal Doppler change, which can either be pulsality index more than 95 percentile in the early weeks, or it can either be AC EFW crossing centiles of more than two quartiles, or cerebroplacental ratio less than fifth centile, or uterine artery pulsality index more than 95. But when exactly are these placental abnormalities started? So when 60 to 70% of is abnormal from the spiral arteries, then Doppler abnormalities are started. Now talking about the complications. Number one is either stillbirth or intrauterine fetal demise, because there is placental insufficiency and chronic hypoxia. They can lead to both of these conditions. Then we have birth asphyxia, because fetus cannot tolerate the labor stress. Then we have meconium aspiration syndrome, because of passage of meconium in utero. then hypoglycemia. Now here we studied that the fetal liver glycogen stores are depleting, so which can lead to hypoglycemia. Similarly, it can also lead to hypothermia because there is less fat. There is poor thermoregulation. Then we have polycythemia because chronic hypoxia in the fetus will stimulate increased erythropoietin production. Then we have necrotizing enterocolitis because of poor gut perfusion and immaturity. Then obviously there will be immunal compromise. Then there can also be neurodevelopmental delay. Now coming on to the management. So the first step of management is monitoring. How will you monitor the patient if the patient is SGA, that is between 3rd and the 10th centile without any abnormal Doppler? Then we will repeat their growth scan every 2 weeks, NST every week and Doppler every 1 to 2 weeks. This is when without any Doppler changes. Then, if it is a severe SG or an uncomplicated FGR, that is if the fetus is less than the 3rd centile, but if the fetal weight is less than the 3rd centile, but again without any Doppler changes. In that condition, again you're going to do growth scan every 2 weeks, but the NST and the Doppler will be done 1 to 2 times per week. Now, if there is FGR with mild abnormalities, and now what do you mean by mild abnormalities? Umbilical artery pulsality index more than 95 percentile. Then we have uterine artery pulsality index more than 95 percentile. Then we have cerebroplacental ratio less than 5th percentile. Then we have MCA PI less than 5th centile. Then we have oligohydramnios, or we have suboptimal fetal growth. These are the mild abnormalities, and in this we are going to do inpatient monitoring if the patient is ready for that. Inpatient is preferred, but we can also do outpatient. Now we will cover the patient with the steroids. We can either give dexamethasone or betamethasone. Then NST 2 times per week. In the earlier one we were doing NST 1 to 2 times per week. Then again Doppler 2 times per week and growth scan every 2 weeks. Now see, growth scan we are doing every 2 weeks in either one. Now if there is an FGR with umbilical artery either absent end diastolic flow or reversed end diastolic flow, then inpatient monitoring, steroids for fetal lung maturation and magnesium sulfate. This is given for neuroprotection. We are also going to terminate the pregnancy in this. If the patient has AEDF, we are going to terminate at 32 to 34 weeks. And in cases of REDF, 30 to 32 weeks. And the preferred mode is cesarean section. If the FGR is uncomplicated, then we can take this pregnancy up till 37 to 39 weeks. And the mode is induction of labor. Then, if there are mild abnormalities, these are present, then we can terminate this pregnancy at 34 to 37 weeks. Both can be done either induction of labor or cesarean section. With this, we have completed FGR, and I will post these cheat sheets on my Instagram as well as on the YouTube channel also. And if you want the PDF, comment on the video below and I'll send you the PDF.